knowing whether or not, you know, they stay up on the guidelines. A possibility for education is when everything is over, being able to say, you know, on Harborview's line, under resources for providers, they have the most latest guidelines that were done by the task force. And the task force is a group of us that do this professionally. We get together every 2 years and review all of the guidelines for both prepubescent and postpubescent and make determinations as to what are we keeping, what are we not keeping. So that's something that you can always offer them as an educatable moment. That, you know, now we're all over. I don't expect you to go online and look it up. However, you may want to do that in the future. And they can certainly always give me a call. I get calls from all over the world as to up-to-date protocols. And then always ask if you think something isn't being covered. Okay? Now, major pitfalls that can actually cause some knockdown dragouts is the differences in informed consent standards. You have a consent standard that is not the same as ours. I will see a patient, okay? Don't worry about it. Our advocates will usually get quite anxious thinking, well, they can't provide services. However, I'm providing services, you know, should they stay, should they go, what are they going to do, and such. So make sure that you understand what the rules are for your agency. Our advocates will usually just stay as a chaperone, medical chaperone, things like that, but they're not actually providing advocacy services beyond their initial response. Sometimes we perceive that you're interfering. Sometimes you perceive that we're interfering. Talk it out. There are things that we will talk about, both of us. Both of us will talk about suicide. Okay, we both need to assess it within our own disciplines. We may provide duplicate information in a couple of areas. Don't get too upset about, I think that you're doing my job, because nurses often struggle with where their role as an objective forensic clinician ends and what they would be as a nurse with, say, a mother that just had a fetal demise or a baby died. You know, they would provide that emotional support. They would provide that crisis intervention. And so teaching them that line, the nurse is the line, is sometimes the hardest thing to do. And then the hardest thing with advocates mostly is interfering with the forensic history and causing that to go awry. Food wars. Never feed or drink a patient unless you have permission to do so from either the ER staff or the forensic staff. It can cause irreparable medical harm if they have to go to surgery. Don't promise any specific treatments. Like if you promise that they're going to get antibiotics and emergency contraception, and now they're at 80 hours, they can't have emergency contraception, and that they're allergic to every antibiotic under the sun, you've possibly harmed the trust between you and that patient. You can say things like, the nurse may talk to you about antibiotics. She may talk to you about emergency contraception. Now, the patient is not going to remember that you said may. Okay, they're going to say, well, you said. Again, don't get bent about that. They don't have good memories going on right then and there. Make sure that if you're addressing concerns with the medical care, don't let it interfere with the care that the patient is receiving. Don't let it affect the care, and the patient should not be aware that there's some sort of disagreement going on. Okay, they should see a smooth provision of care. There may be discussions outside of the room, but they should not be aware that there's concerns going on. And again, know what the available services are. Know who you're going to face when you get to the emergency room on a clinician level. Know what the ER politically is willing to do or not do. And know what resources you have for your community.
That was great. Thank you.
Okay.
I think we're good.